Thank you for joining us. What we may see is we had, excuse me, over 80 people sign up for the conversation, although I do know that a number of people listen to the recorded conversation at another time that works more conveniently for their schedule. But we have a lucky 13 on the call right now, and I imagine that we'll have a few more join as well since we just started at the top of the hour. I want to introduce you to our staff that are supporting the PFCC Informal Connect conversation. One of those individuals is Pam Dardis. She's Vice President of Strategic Initiatives and Outcomes, and she will be our chat monitor. So we recognize and encourage people to chat during the conversation. And Pam, I don't know if you wanted to say anything to folks, but feel free to chime in at this point.
Just welcome to everyone, and I will see you in the chat.
Okay, great, thanks. And then the other person who is absolutely critical to the success of this conversation is our behind-the-scenes technical person, our healthcare program and communication specialist, Annette Lee. Annette, are you going to join us for a moment and wave to the crowd?
Hello, I'm here.
There you are. Great, Annette. It's always good to see you, and thank you so much for your technical support. Now, Annette will, if you're having technical difficulties, please chat them into her, and she will, in fact, be the individual who tries to resolve those. I can moderate a verbal conversation, but when it comes to the technology, Annette is our go-to gal. So great. Thanks for joining us, Annette. If you'll go to the next slide. As you know, our informal conversations are just that. They are not a webinar. Although there are a few slides to just keep us focused, we together will create this conversation and make it meaningful to meet your needs and to advance patient and family-centered care in the behavioral health arena. If you would, we'd appreciate it if you chat in your name and organization. We're going to use some polls at the beginning of the conversation to learn about those on the call and your experiences. The goal really is to share whatever experiences that you've had, questions that you've got to ask the other members of the informal conversation. The good news is we are recording the conversation. We keep a log of the chats because often people share resources within the chat as the conversation is going on. And then all of that is loaded into PFCC Connect in the behavioral health folder and will be sent out to you with some links at the, a couple days after our conversation. So we can go to the next slide, please. And I'm watching the chat. A lot of you are chatting in, and I love that. We've got people from a variety of areas. I'm going to try to move my chat somewhere where I can see it. This is great. We've got people in Minneapolis, Fort Worth, Kansas City, Washington, D.C., and of course, I'm in Eugene, Oregon. Am I the only person representing the West Coast? I hope not. This conversation came about because this is an important conversation that's happening across the healthcare continuum as it relates to how do we best serve and engage patients and families, often in the behavioral health arena, in community settings. We use the word clients, whatever is the terminology that's most respectful and requested by those with behavioral health conditions. But I went out and did some just looking just at the numbers because this is such a big conversation, both because of the opioid crisis, but also because of the challenge that we have in primary care in connecting individuals with behavioral health issues to resources in the community. And 4.6 million adults in 2017, 18 or older, were diagnosed with some kind of mental illness, and that's almost 20% of all U.S. adults. And then, of course, there's the teen population and children with autism and other behavioral health issues and challenges. And so clearly this is something that covers and touches a number of people, because if you're not one of the individuals who has is living with a chronic condition that is a mental health or substance use disorder, then you possibly and probably do have family members or friends with whom you interact and care about who do have those conditions. And so we want to make sure that in our healthcare arena that we are implementing and providing care and creating partnerships with those with behavioral health conditions, in utilizing all of the really important concepts of patient and family-centered care, that we're treating people with respect and dignity and valuing their lived experience, that we're providing information in useful and affirming ways, that we support and encourage their participation in their care to the degree that they choose, and that we recognize that families are defined not just by blood relationship, but by emotional connection. And how are we inviting patients and families to be involved? And so we really appreciate that this is an important conversation to have. Next slide. So let's find out who's in the room right now. Annette's going to set up a poll. Please click on what your healthcare setting is so that we can understand, of the 20 of us that are on this call, where are people kind of hailing from in terms of where are they working or contributing to care in the community, which settings. So I'm going to give a minute for that poll and grab some water. I recall working with some patients and families up in Bellingham, and one of the things that they shared with me is that we as individuals receiving healthcare live in communities. We don't live within organizations. Although we may give care in a particular setting, people are really living in their communities. So it looks like we've got a nice mix, a few behavioral health community programs. I'm so glad to see that. We've got some primary care. The largest group is other hospitals or medical centers that don't necessarily have a psychiatric program affiliated with them. And then I am interested in the others. We've got about 20% of people, that may be one or two, given the number of participants that we've got, and that number is continuing to grow, that are from other kinds of settings. So feel free to chat that in when you're chatting in. And I see that the numbers are growing in those that have joined our conversation. So feel free to chat in that you're here and where you're from. And we're going to go ahead and close this poll. It's helpful to know where people are, their setting and work environment is. And I'm going to ask you to complete one other poll. And that has to do with what's your role in your current organization or in your community setting. If you'll take a minute to do that, that's always helpful for us to just know really quickly. And what you'll notice on this quick poll is that we really have been fairly inclusive of all the different roles. And I realized that I didn't put down other, because even though we try to be inclusive, I'm guessing that I may have missed a role in there. But you can feel free to chat it in. I'm really glad to see that we've got patient partners and we've got clinicians on this call, and those that are coordinating PFCC initiatives. Great. Well, we can go ahead and close that poll. Probably the most important poll is the next one, which really is, we are 28 strong, and we have a little less than an hour to have our conversation. So we want to make sure that we're talking about the topics that are of most interest to you. Now, there are two ways that we find out about the topics that are of interest to you. One is that a number of you, but not everyone, submitted questions that they wanted to have covered. And in the next slide, I will be sharing what those questions were. But I'm also interested in those of you that may have joined or registered after I received the registration on Tuesday. If any of these topics in particular are of importance to you to cover in today's conversation. So if you can check any that apply, but really this is your opportunity to kind of let us know what the priority is. And then I'll manage the time and pay attention to both the individual questions that came in, but also the general topics that people have indicated that they want to have a conversation about.
The Institution of Family
Just give you another couple seconds to fill out that poll. And for those of you that may have just joined us, just in order to keep background noise to a minimum, if you can mute yourselves, except when you're talking, that would be great. We appreciate it.
Can't hear anything.
Okay. So we've got really the majority of people are really interested in how to engage those who have a behavioral health issue in healthcare improvement. That's 92%. That's pretty significant.
I know I need to.
About half are interested in engaging patients and families in direct care. And then the next item is really working with unique populations. So we will see how we do on managing the time and getting to those kinds of things. So if we want to go ahead to the next slide, Annette, please. So these are the questions that came up, and they will stay in front of us during our conversation. And let's start. Since we have 92% of the individuals on the call are really interested in how to engage clients and families in healthcare improvement that have behavioral health, substance use disorder conditions, it seems like that is, for those that have shown up, that's something that you're very interested in. And so what I'm wondering is, as I look at the questions that came in beforehand, one question that came in that has that's specifically related to that 92% is, what kinds of ideas do people have for recruiting and addressing challenges that patients and family reps might have for participating in the PFAC? And what are some successful strategies that other individuals have used for working with patients and families on improving care in a behavioral health setting? So what I want to do is I want to open it up. I don't necessarily call on people, although there are a couple people who have indicated that if they have something to contribute, they're comfortable with me calling on them. But let's start just on finding out, is there anyone on the call that actually has engaged clients and families with behavioral health issues on improvement projects?
Yeah. I haven't. You should put it, or do you not have it open?
I hear somebody talking, but I'm not sure you're talking to us directly. Anyone? So let me just share some experiences that I've had in working with individuals who have are living with chronic mental health issues. I have, and then let's see if that, and as it relates to improvement. So I worked as the quality director for the multi-specialty practice, which was affiliated with a hospital that also had a psychiatric facility, a locked facility. So, and it was the main mental health program that was secure in the in the area where I lived. And we recruited patients who received behavioral health services from our outpatient facilities and departments for our general patient and family advisory council. And we utilized, in terms of recruitment, we utilized the psychiatrists and the counselors and the psychologists that worked in our outpatient program to identify patients, clients who did have behavioral health diagnoses, but were in a good space, were in their recovery, who might be interested in serving on our advisory council. And we found that that was the most effective recruitment method. And then we would reach out to them with, of course, their permission. Their psychiatrist or their counselor contacted them ahead of time and recruited them and oriented them the same as any other advisor to the program. But they represented the behavioral health services line. And we found that that was a very helpful recruitment effort. And we integrated them into our ongoing efforts to improve care across the continuum. And often our advisory council was contacted by our hospital forensic unit, psychiatric unit, to utilize the advisors to get assistance and thoughts from them about input related to programs that we have. So, anyone else work with patients and families in the behavioral health arena?
Hi, Mary. This is Avelina Ortega.
Hi, Evelina. How are you today?
Good. Thank you for asking. I recently started in behavioral health, although I still run our ambulatory council. And we have pretty robust activities over here. We have peer support specialists. We have a board of patients along with the peer support specialists who participate in the monthly board meeting. But the peer support specialists are involved in improvement in the clinics and inpatient. But I agree with you that enlisting the psychiatrists and the social workers and nurses and medical assistants actually seeing the patients is the best way to recruit, because they have that relationship with the patient. And when they ask the patient, it's different than it's coming from someone that they don't know. So in my limited experience here, that's what I've learned.
Great. And can you talk a little bit about your peer specialist? Describe that role and how they're involved in improvement efforts within the organization. Are they paid staff?
They are. So we have sort of a tiered approach. They have to volunteer for a certain period of time. And I was hoping Penny, their supervisor, was on the call. Penny, are you on? She might not have been able to get on, but they volunteer for a certain period of time. It's like 90 days or something like that. Then they can actually qualify to become a peer specialist, which is a paid position. And I believe we have 4, maybe 5 peer support specialists. They actually do take a certification through the state to become certified, but they work both inpatient as well as in the clinics. And they do a variety of different things. They meet with patients to help them through difficult times, as a peer who's been through it. And so they're just like we involve our medical assistants and our providers and nurses in improvement. The peer specialists are just as part of the team, and they participate with us too.
Great. That's wonderful. Thank you so much for sharing what you guys are doing in your setting. I noticed
we have more in a couple 2 or 3 months. So
great. That's wonderful. And oftentimes organizations that have peer specialists may start with peer specialists, but they want to expand beyond that and invite those who who have, obviously peer specialists have a lived experience, but those that are receiving current care from the facility is really important. And I noticed that Claire asked a question, and I want to respond to it, but there may be others that have a perspective. She said, how did you navigate identifying the former clients on the council in terms of confidentiality? And remember, I was talking about on our council, we had people representing different departments from the medical group. And obviously it was a mixed group of patients who may have received primary care, or parents of pediatric patients, or individuals who received counseling or services from our behavioral health department. And what we did is we, as part of our orientation, did information about confidentiality generally, because people will share their stories, whether they're behavioral health stories or they're, I broke my arm and here's how I experienced care in the orthopedic department. All of those stories, personal stories, are privileged and private, and we need to respect confidentiality. And so in terms of our orientation, we were very clear about that, and people signed confidentiality statements. In terms of, we just let everyone know on the council that they could share that which they found most important, and what they chose to self-identify or not was up to them. We just knew that we had individuals who had particular backgrounds that were effective. And so, for instance, if the hospital was contacting us because they wanted to get feedback about something they were going to be doing in the hospital setting that would have impact clients with those particular conditions, then we would just generally announce to the council that we wanted to get feedback from families and individuals with those lived experiences, and they could let us know if they wanted to be involved. And they could let us know in the meeting, or they could let us know later. And again, we set it up so that there was a lot of choice that was respectful of people's confidentiality. What we found is, as people began to build trust and they understood confidentiality, they took it very seriously, and people did self-disclose. And that was okay because they felt like it was a safe environment to do that. How do others navigate the whole issue of confidentiality? Evelina, do you have a particular process that you guys go through? Or others?
During our orientation process, we have them sign a confidentiality statement. And then I also mentioned something at the beginning of every PFAC meeting.
Great. That ongoing reminder.
It's like, yeah, it's a standing item on our agenda.
Yeah, that's great. That's great. What about others? So let's think about different ways that, since 92% of you were interested in how you engage clients and families in healthcare improvement, and one was making that personal relationship and helping them understand how the referral came to be, and then providing them with information about, what the opportunity was for contributing. I know that there are a number of organizations across the United States. They don't happen to be on this call, but for instance, Contra Costa Medical Center involved all patients, invited patients who received mental health services from their organization to participate in a rapid process improvement workshop on a problem that had been identified both by clients but others in terms of their how patients received care when they came in under acute conditions to their emergency department. And they did a number of improvements related to that. And they involved patients and families on that improvement work. So there's always the improvement that happens through established monthly patient and family advisory council. And then there are project-specific things that come up. Has anyone worked with or has a behavioral health patient and family advisory council that's only specific to that particular unit? Anyone on the call related to that?
UNM does. I just started going to it. I've only gone to, there's one meeting so far, but it's specific for the psychiatric population. We have like a separate building that
Mhm.
houses a lot of our behavioral health services, including excuse me, psych emergency. We have an urgent care, and then we have a bunch of outpatient clinics.
Mhm.
And that group is just solely behavioral health patients and family members.
Great. And so they're working on issues related to all the services that you just described being
Yes.
provided.
Yeah. It's pretty awesome, actually. I think they have about 10 patients, which is, I think, is impressive.
Cheryl, you chatted in that Children's Mercy is planning to start a PFAC this fall. And so staff members are recruiting for that PFAC. When you say staff members are recruiting, are you talking about the behavioral health staff members are recruiting or members of the patient and family centered department?
It's really the behavioral health staff members are currently recruiting and starting to identify those patients. This has been a push from our chief nursing officer and has requested that we do that. We do not have a behavioral health inpatient unit, so we need to partner with our parents of our patients to help us figure out a way to help those patients before they are transferred out to the appropriate facilities.
Oh, okay. So they're going to be really working on some transitions of care initially.
Yes, and then also while they're here for other medical procedures, so while they're hospitalized for other things, how to meet their needs while they're here.
That sounds great. That sounds great. Anyone else working on that particular, the establishment of a new PFAC related to behavioral health?
This is Trish Anderson from the Washington State Hospital Association. Can you hear me okay?
I can, Trish. Thank you.
Thank you. I'd like to share something that bore out of what I would call a quasi-patient complaint, reduced access in our community, a very well-off community, but very challenging to get behavioral health services in the perinatal realm. And that complaint generated a patient and family advisory council for Women's and Children's Services at my previous work. And then from that, we were able to go to the foundation and establish perinatal mood disorder clinic. So there, from inception through the visioning and operationalizing over the course of a couple of years, we have now a preconception, interpartum and postpartum perinatal mood disorder clinic that came forward from a challenge that one of our patients identified. So wanted to showcase a quality initiative that was profoundly effective, and we really listened carefully to what our patients were saying about the care that they could access.
That's a great example, Tracy. Thank you for sharing it. And so from complaint to actually developing program services was about a 2-year period?
Maybe 3 to get it fully operationalized. It just went live in January. Yeah.
So as you know, it started with the patient complaint. How did you involve patients and family members in the development of the program services, or did you?
We sure did. So as we continue to socialize the idea about what our vision was with providing that services and individual and group therapy for our peripartum patients, perinatal patients, we continued to identify other patients that had those needs, and whether they were in treatment, seeking treatment, or to help us evaluate what would be most beneficial and vet our ideas that they would be realistic. So it changed from a traditional 8 to 5 model to a 3 to 10 o'clock in the evening, Saturday and Sunday model. So a lot of our mothers and fathers were, trying to maintain work and help them reduce stigma by not always leaving the workplace for medical appointments. So we tried to be very sensitive on when we could most likely meet their needs. So our business plan changed quite a bit, and it allowed us to take a clinic that saw mothers and babies and families during the day for postpartum breastfeeding and follow-up to maximize that space and offer continued services into the evening and kind of get double use out of that space because we expanded the hours.
You know, that is such a wonderful, that's such a wonderful story, Tracy, and I hear it so often that when we listen to what patients and families say that they need, and we have them continue to work in partnership with us to fill that need or address that need, we often end up going in a whole different direction than what we might have thought about putting in our heads about what would address that need, that they really are the experts on what is going to be the service that's going to be most beneficial to them. And it does require flexibility on the part of the organization, although you have to set, you know, boundaries and limits, but that often we end up in partnership with them creating something different that's useful and more effective than if we'd taken the complaint and gotten into a room on our own and come up with something. So thank you for sharing that story.
Thank you.
Have others had the opportunity to listen to patient and family feedback and develop changes in their program services as a result of those stories or that feedback from patients and families?
This is Janice Tefty. Hi, I'm a patient partner, and I'm involved with Kaiser Permanente Washington State and other Title 19 and local healthcare for the homeless. And so I have somewhat of an understanding of the overall kind of global aspect of it from the local most vulnerable many people living with, you know, with experience who are really unable to access care. You know, the homeless, even though we have Medicaid expansion, because there's so many individuals seeking assistance, it's just so, they have weeks, if not months of waiting to get in to see providers, community, resource opportunities, as well as even if they have a crisis, you know, it's really an issue. There's not enough hospital space. So, anyway, and then at Kaiser, now they've added on a number of individuals for working with clinicians and mental health providers. Like, I think they hired something almost like 10 new people because there has been a lot more demand. And something we haven't discussed here, which I wanted to discuss, are two different populations. One is the youth. And one of the reasons I actually asked a psychologist, can you tell me why there's more of a demand? Is it because there's less stigma? And she said, one thing, yeah, that's right. And it's the younger population doesn't necessarily have the stigma that perhaps the baby boomers live with, right? So it's okay for them to go in and talk to somebody, whereas with baby boomers, people might have been quiet about it happening. So we have more youth that are seeking services, and that's kind of a specific group, as well as the aging population. And both of them, it's hard for them to get in to receive services. So I think that each area, wherever you live, that there's a specific populations that you might be serving that, you know, the supply and demand needs to be met, which comes to a state level often, if not a federal level, of requesting for more assistance. And the patient voice can really be there to help initiate and advocate for those needed, services.
And Janice, would you extrapolate that you think because not the baby boomers, but the younger population is more interested and creating demand for behavioral health support and counseling and things, that they're a great resource to assist us in figuring out how to best meet the need?
Yeah, I do agree. And it really surprised me. I mean, it came from the psychologist I was talking to, right? I mean, I asked, why is there such a demand? I thought it might be because of our environment or, whatever, just America today. And she said the youth just don't have the stigma, but they have the need and they feel it's all right to come in, whereas before there had been somewhat of a stigma. So I do feel that in youth, I'm talking about individuals under 30, whatever, right? that they are a great voice that we should tap into, because I feel that they can help share with individuals who might still have the stigma of just going in and talking to somebody when they're depressed, grieving, or whatever, that can lead to, even maternal health, that can lead to something much more dangerous if they don't receive care. And I think their voices can help. But, as it goes in populations, people say, well, I don't relate to them because I'm not young, or, I don't relate to them because they're older. So I do think that they can carry the ball forward, and the peer support through them is a really important voice to help.
Great. Thanks for sharing that. We're kind of segueing, we're about halfway through the conversation in terms of time, and I want to be sensitive to the fact that a number of you were interested in chatting about how to engage clients and family in direct care. And if you noticed on our questions for discussion, there were a number of questions that were about how can hospitals and healthcare organizations do more to listen to the voice of the patient, but also how do we in non-behavioral health hospitals, in the EDs, or even in the mental health field, how do we encourage and support those staff in inviting family to be part of therapy, to be part of the care team on admission versus as part of discharge? And I am interested in knowing if there are some folks on the call that want to kind of have a conversation around that whole issue of engagement in direct care. I know for years, and I worked for 3 years, when I was a youth, according to your definition, Janice, when I was a youth, I did work in a forensic psychiatric secure hospital setting as a psychiatric security aide, and saw that there was some stigma about inviting families to be involved in a proactive way, and in working with a number of behavioral health hospitals that went through the PFCC journey and created welcoming policies for families and those kinds of things. There was that whole issue of how are we respectful of the client, and isn't often when those conversations started, it was, well, isn't the family part of the problem? And so let's exclude the family. And I think that in a patient and family-centered care environment, we want to be to understand the role of family in being positive and proactive. So I know we have a couple clinicians on the line, and wonder.
Yeah, hi Mary. This is Dr. Patron. I feel like you were actually reading my comment and question. Can you hear me okay?
Yes, I can, Dr. Patron.
Yeah, hey everybody. Dr. George Patron. I'm a retired Army pediatrician who in my entire 23 years was always a patient advocate for children, of course, sex abuse, subspecialty expert, developmentalist, behaviorist, and then a family advocate. I've retired now, and I spend my time pro bono advocating for families that come my way, and an alliance that I've formed of people from all walks of life. What Mary is talking about is my frustration. I live in San Antonio now, and we got a great community that talks like we are integrated and inclusive. But when people I represent, which are that young age, the 20s, most in the 20s, have mental health needs, they're not speaking well for themselves. They're not able to, depending on their condition, whether it's actually sorted out, diagnosed or not. And when I come along as the only family they have, I have instructed them or advised them they should fill out a release of information form, an informed consent form, as they're asking me for help. I find that especially the mental health facilities close the door because they say HIPAA or otherwise, we can't allow anyone else to come in here, even when the patient is saying, I want them in. No, we that's thanks, Dr. Patron, but we don't need you. And so I marvel at that why of all patients with conditions that can't speak for themselves, we don't allow family in who they trust to help out. So I'll just say that I have found in general, of my good colleagues here in healthcare in San Antonio and Bexar County, they don't allow family in, whether they're bio family or not. they think they can do it on their own. And after the admissions, when I'm trying to help out and I go back and try to make appointments, I find they say, we don't need any help from you, kind of an approach. So that's really concerning for all of us who know the importance of families, of getting their input, yes, on admission, especially for mental health needs, because we know what's going on. Yet there's this attitude of keeping us away, just as you said, Mary. So I'm interested in places that have been able to undo that, because so far I've been unsuccessful here in San Antonio.
Well, don't give up. So what have others done in terms of moving that culture? Because it really is a cultural shift.
So this is Claire with Cohen Veterans Network. And this is something we haven't done as much of as I think we'd like to yet, but we're moving towards it, is doing just a little bit more education with the client about the care that they're going to be getting, making them feel like they understand it a little bit more, and then also the role that their family could play in their treatment. Because CARF, we strive to have CARF accreditation for all of our clinics, and CARF really emphasizes the need to have family members involved whenever possible. So educating them on the importance of having the family support. We focus on military and veterans, and there is already so much stigma around asking for help, the idea of appearing weak to your family. So a lot of it is kind of breaking down those barriers and providing that supportive education to let them know, like, this is engaging your family is A, not a sign of weakness, and B, will actually make it so that your therapy hopefully will be faster, better, more effective, et cetera.
Claire, that's really a good point about, it's important that one of the interventions is really supporting and encouraging individuals, clients who are experiencing the condition to get permission and begin to understand the value of family being involved, so as to address the stigma of, I've got to be tough, so I don't want to get anybody involved. What have you done, if anything, and this is to Claire, but it's also to the larger population, to really do that have those same kinds of conversations with clinicians and staff who are delivering the service, the behavioral health service, so that they can break the myth of that they're the kind of the heroes and they're going to do it all, and they can do it in a way that excludes family, and that's okay. How do we break that pattern down and invite more comfort with the idea of the role of families in recovery and treatment?
Yeah, no, that's a great question. I think that's something that we are still working with. All of our clinics do offer family therapy, and we offer family therapy without the veteran involved if need be. So like if you know your family is in need of treatment, but your veteran is really resistant, your family can come in without the veteran, and that's fine. We encourage it. But I think, to your point, Mary, I think there is so much work to be done on educating the providers. And I think part of educating the client is to sort of level the playing field of it between provider and client, right? Like, we want to make sure that our clients understand the difference between EMDR and DBT so that they can make an informed decision about what's going to be the best fit for them and not have to rely on, like, oh, well, you guys are the experts, so you know everything. No, you're the client. It's your care. What do you think, you know you best? What do you think is going to work best for you? And how can we better educate you so that you can make those informed decisions? And then I think something that I hope we'll be able to do more of is work with the clinicians and say, like, okay, so then how do you broach bringing the family component into this when you're doing the biopsychosocial assessment? When are you asking those questions about, like, is your family involved? Are they supportive? Do you think they'd like to come in for treatment if necessary, et cetera? And I think that's something that we're trying to do more of, but we're definitely not there yet. And I would love to hear how other people are doing that.
Hey, this is George Patron. I just want to weigh in that here in San Antonio, the Cohen Clinic is one of the bright spots here for doing exactly what I think it was that Claire was saying that is what they're trying to do and wanting to do. I just had a recent client, was brought to the Cohen. I brought him to the Cohen Clinic, actually, being military myself and knowing about the clinic. It's a wonderful clinic, and the fact that they include family is so out there, great. What we all need to do more of is ask the question, who's your primary caregiver? And I'm at a conference today, actually here in San Antonio, on the regional health program with Medicaid. And we're talking about these issues all day today. But is to ask the question, who is your primary caregiver? And then who is your family? So that when we're working on therapy, if we're not going to do the primary care, asking all those important primary care medical issues as well as psychosocial determinant issues, that we help the client line up a place. And of course, that's the problem we all deal with, right, on this call and otherwise, is who's your healthcare plan? Do you have insurance? And as we all know, having insurance does not give you good health care in this country. It just says you have insurance. So that's the one thing that the Cohen Clinic, I'm working with them on here, is that this young man still has no primary care. So he is discharged from the program, and yet he's still out there floundering. And I'm not a clinician anymore, and I'm a pediatrician anyway. And this is a person in his early 30s now. So that's something we all need to work on. That's a part of addressing patient-centeredness, family-driven, and focus, is to make sure that when we hand them off, we're working with their primary care group. And if they have no one doing that preventive medicine aspect and case management, care coordination, we need to somehow establish that in our communities.
So identifying at intake that this person doesn't have primary care, and then making that be a part of their treatment, is the case manager is in identifying primary care for them for transition out.
Exactly.
Got it. Okay, that's awesome.
And what we're seeing across the country, I just was listening in on a webinar with the Transforming Clinical Practice Initiative, is that there is more and more uptake of integrating behavioral health into primary care and vice versa. So primarily mental health programs are beginning to invite primary care providers to do office hours and things. If the main place somebody's receiving their care is in the mental health, behavioral health unit, outpatient unit, that they're creating connections between those. And I think what, as we think about what really moves change, and especially culture change, it's a combination of two things. One is, especially with clinicians, it's data. What data is out there about the impact, the positive impact that happens when families are integrated into care. And we proactively ask those really two important questions, George, that you surface, which is, who's your primary caregiver, and who is family, as you define family, that are the people that you rely on when you are not receiving care in a system, but you're out in the community living. Who are the people that you rely on to assist you with that? And then, so data is one thing. So, and there's a lot of really good data out there now about the impact and the positive impact of involving families in care, not just behavioral health care, but care in general, but also with mental health and other issues. And then the other is the power of stories. And they don't have to be necessarily the story. It can be your story if you're working in an advocacy role, but it can be the stories that you hear of other places. I was just recently talking to somebody who is the sister-in-law of somebody with a mental health issue, and her story was that no one at the ED contacted them that the sister-in-law had been transported to the ED, and they released her, sent her home in a cab. The family was scrambling to try to find her, and she basically got dropped off, not even where she lived, and was wandering in the community for 2 days with a pretty acute mental health issue. And when the family found her, of course, they gave feedback to the hospital. And then when she had to be readmitted to a different hospital, the family went there and demanded, in a respectful way, that they be involved in the admission and along the way, because they were the ones that were going to help keep her safe in that transition to care. And that was a powerful example of what happens when you don't involve family and you have people who are very vulnerable, and hospitals, especially those that don't have mental health beds, are discharging people into the community in ways that are not safe. And so both data about what's going well and the outcomes that are happening, and also powerful stories, both positive stories. This one was not, it ended up being positive because the family really did partner and show that hospital in a positive way, the positive impact that could be made. But it was, it was a difficult experience for that family and for that individual who was wandering in a community, not altogether knowing how best to be getting what she needed. So,
Mary, this is George.
Go ahead, George.
That's a great example. That's a great example of what we're talking about. I just want to share with the group that when I speak at conferences anymore, and the 4th year the University of Oklahoma is putting on next fall, the Integrating Primary Care, Behavioral Health into Primary Care with a Focus on Prevention conference. And it's a public health prevention really push. I have said there to the folks who attend, and I say to all of us, I didn't do when I was the clinician in charge. And that is to say, when we first meet our clients or our patients, hopefully in a primary care setting when we're setting up a medical home, but yes, even when we're admitting for a specific need in a hospital, is we should just ask that question straight up front, not only DNR a situation if it's a serious condition that is life-threatening. Who do you trust? Who do you want informed if you are unable to make a life-sustaining decision for yourself? And along with that stigma we brought up, I realized they can say, wait, what do you mean? I'm not suicidal. I said, no, that's one situation where sometimes people feel like they just don't want to go on. If I'm talking about any of us can go out and get into an accident, knock on wood, God forbid, and not be able to make decisions. Who do you want us to call? And that's either short-term on this admission or long-term. And as a primary care physician, I advise my fellow family practitioners, pediatricians, etc. I hope you would consider me to be one of those people who you would call or have your family call. I'd love to be on that list for you, with you, because I care about you. Mm-hmm. If we did that action, we had that legal piece of paper there that says we can call people not for negative reasons, for a positive reason, I think we would start to learn who those trusted quote-unquote family members are.
Mm-hmm. Mm-hmm.
An idea.
Excuse me, this is Trish Anderson calling again from Washington, or speaking Washington. We just enacted a change in the definition of family and who can be contacted and included in that definition. And it is around advanced care planning. So it'll help us with some of the patients who are residing in our hospitals who have behavioral health and we cannot identify their actual family, but they've identified other people who they would classify as family. So you might want to look to Washington's most recent law change around the definition of family if you wanted to take a policy approach to solving the problem, partly solving the problem. So I just wanted to build and add on the previous speaker, and thank you for
This is Janice, and I'm in Washington State, and I think we're kind of somewhat leaders in this area. And with patient and family advisors, there are some patients whose family has been part of the primary issue that has exacerbated some of their behavioral health or mental health issues, and they don't want to be a part, they don't want their family to be a part of it. And we find this particular with at-risk youth and just other groups. I mean, it could be a divorce, it could be a DV situation. So it's really important that we also look at the aspect of family as one, might be a household or whatever, that individual might be one, and their support system might be the peer support group themselves. And like you had mentioned, we in Washington State really look at family as who the individuals identify as family, not necessarily blood, and how they can have them in for their assist them with their medical care and other aspects in their life.
Yeah. So Tammy's put in a couple chats, one of which, Tammy, you were talking about that you noticed that in Massachusetts that there's more and more initiatives where they're partnering with PCP offices and mental health. Can you describe any for us that would be useful to understand?
Sure. Can you hear me okay?
Yes, I can.
Okay, great. Hi. So the first program that I had heard of, I actually applied for a job there about 7 or 8 years ago. There's basically I want to call it almost a mental health hotline service that began, and I'm blanking on the name right now. Paula Griswold, if you're on, you might know the name of it, but it was a mental health support service line for physicians and practitioners in both PD and adult practices, where it's like a behavioral health initiative, where if you were presented with a patient that obviously was going through a mental health crisis or was experiencing symptoms, you could basically call this line, describe the symptoms, and get help to sort of triage them to the right kind of care. Did they need to go to an ER? Was there a bed somewhere? Were they at risk of self-harm? To kind of be able to triage them, stage them, and figure out where they needed to get care. It had to do with the supply and demand, or lack of supply, right, of licensed mental health practitioners in the state versus the number of patients seeking appointments and seeking care. And so that was the first initiative that I heard of that I was really excited about. The second one, though, was in my own son's pediatric office, where being that I was a patient advocate, but my background had been in quality improvement in healthcare, I had heard about a separate set of ideas where it was kind of like the therapist down the hall, the notion of why not build capacity for therapists to be in the same practice, but down the hall, so that you could refer, so that you could have someone on site that you could say, again, supply and demand might be mismatched, but at least if we can have practices work together to have nearby therapists that they could refer to, it would provide much better continuity of care for and patient-centered care for practices. So those are the two things that I have heard about. And the other thing that I just wrote about was I was very lucky as the mom of a child diagnosed with complex congenital heart disease, because Boston Children's, I found out sort of on a fluke, had this, he was going in and out, my son was going in and out for surgeries and procedures and so forth for his whole early and middle childhood, and began to experience some signs of PTSD, which no one had ever forewarned us about, and we knew we all had stress management issues, but as a sidebar, I'd like to say, I think that as a healthcare system, we could do a whole lot better at previewing that for families, whether they're NICU families, for example, or with kids or people diagnosed with complex illness. That should always be a component, and I always feel like that's the missing puzzle piece. That sort of, we need to get better about talking about that and giving people a heads up that they may need those services. But Children's had this wonderful coping clinic, which he started to use when he was 6 years old. And they were my heroes because they helped lay out, not just for Jameson, but for our whole family, ways in which we might need support and ways in which we could get that support. So I kind of wish that for everybody, but I also wish it to be, really well integrated across the entire system.
You bet. We have so many wishes in this area, and we're going to keep working on them and working on them together. We need to kind of wrap things up, I want to be respectful of people's time. Can we really quickly, Annette, go through the next slides? I wanted to share with you a couple things. Next slide. Some organizations that are doing some pretty cool stuff. So those of you that are in the inpatient psychiatry world, you can learn about what University of Vermont Medical Center did in terms of implementing a welcoming policy in their psychiatric unit and how that went. And so it's pretty awesome and is very inclusive of families. Next slide. There also is a wonderful program where curriculum was developed for people living with behavioral health issues to become leaders and change leaders. And Sonia Ballantyne has created an inspiring change manual and can talk about her journey as someone with lived experience, but then also now as an advocate and a facilitator of other people moving into roles where they have influence and over healthcare changes. So that's a resource for you. Next slide. And then this is a great example of partnership at a neuropsychiatric hospital. Glenn is on their Patient and Family Advisory Council, and they started by telling stories with different faculty to really change the culture. So he's got a great story to tell, and you might be interested in learning more by contacting him. But they were really working on how to support wellness and recovery for patients and families. Next slide. And then I haven't worked directly with this program to the others I have, but I was looking at what was going on with youth, and the LA InnerCityStruggle.org is working with youth to really improve the trauma-informed mental health services in the LA area, and their story is pretty powerful, and you can learn more about it on their website. Next slide. So if you are not a member of PFCC Connect and you want to continue these conversations, because you don't have to be a member in order to have a first informal conversation with us, we encourage you to do that, to join us. Next slide. And we have another conversation coming up around measurement, tracking patient and family engagement activities and outcomes on August 1st. So feel free to register for that if that's a topic of interest to you and you want to contribute and be part of the conversation. And our final slide is just really this is what happens next slide. We're going to put all these resources onto PFCC Connect, and you'll have access to them. You can ask more questions virtually, not in a conversation like this, and you'll find that other members of the community will respond and share ideas with you. And we'll put all of the materials that we've shared today onto that site as well. And we want to thank you for joining us. I know I kept you an extra couple minutes, but boy, was this a powerful conversation, and I didn't want it to end, sorry. But if you have anything that you want to talk with us about, feel free to call us, or actually email us, and then we can get in contact with you. But thank you very much for being here and for being passionate about this very important population of people who deserve respect and dignity and involvement in their own health care. You make a difference, and continue your advocacy and your ongoing work, and share with us your successes so we can pass them along. Have a great day, everybody.